take away the pain of a thoracostomy drain, because the parietal pleura, which has the innervation of the phrenic, will not be blocked by the lump, the thoracic epidural. The lat dorsi from the thoracodorsal and thoracic nerves, and if you want to control, you know where to place the catheter tip. And the forceful retraction for which the surgeons who need access actually damages the intercostal nerves, other than the fractures that they create, leading to intercostal neuritis, which is one of the major causes possibly of the post-thoracotomy pain syndrome. And the other sites which are also damaged due to these retractions are the anterior and posterior intercostal articulations, whether the costovertebral or the costochondral. The position of the patient, especially if it's a long duration surgery, the way the shoulder is can lead to a generalized muscular pain as well as shoulder pains, which can be also very, very difficult to treat in the post-operative period. So what then are the consequences of this acute post-operative pain? As I discussed, that because of this pain, because of this inability to take deep breaths, because then the incision gets stretched, the muscles get stretched, the expiratory muscles get splinted, and consecutively the diaphragm also gets splinted, all these leading to a decrease in your FRC, which ultimately leads to atelectasis, shunting, and hypoxemia. Respiratory failure we alluded to initially. Finally, because of this inability to take deep inspiration and this inability to have a proper cough, it will promote retention of secretions, leading to early airway closures and atelectasis, and possibly because of this retained secretions, these patients may have a chance that they would need intubation just for pulmonary toileting. And any intervention on the airway we know can lead to an increased incidence of VAP. What then are the current treatment options of post-thoracotomy pain? Epidurals. They have been the gold standard. They provide very good analgesia, but remember that they will not be able to treat things like shoulder pains and pain due to a chest drain. And they bring along with them some things that you don't desire, like motor blocks. You have a bilateral block, and you can cause also hemodynamic alterations, sympathetic blocks that comes with it. Epidurals have been possibly the best ever since we have been doing, at least I did my residency, we have been taught that the gold standard and the best modality of treatment for thoracotomy pain has been the epidurals. And it has been good for non-pain reasons too, because since they also block the cardioaxillary fibers, that people, a person with a ischemic heart, an epidural for a person undergoing thoracotomy can be beneficial for that reason as well. And this was one of the seminal publication by Ballantyne, which showed that actually the modality that improves pulmonary outcomes after thoracotomy is a high thoracic epidural. What then are the other ones? Intercostal nerve blocks. It is simple to do. You all know that we need to put it in 5 spaces, 2 on the place that it is cut, as well as 2 above and 2 below. You can give it as a single shot. You can put in as a catheter-based technique, and it works well in things like a video-assisted thoracic in port surgeries, where you can actually pinpoint and may not have to do so much. However, at the point at which you give, the posterior part is spared, so you can have pain over there. And there is this theoretical concern that if there is a no tube in situ, you run the risk of pneumothorax. Is it any good? This particular publication, which has been very often quoted, says that intercostal nerve block with a PCA, IV PCA, is possibly as good as a thoracic epidural. And this person, there's another publication, in fact a plethora of them, which came out in the 2004-2005, is that intercostal nerve blocks alone can be effective in treating post-thoracotomy pain. Taking it a step further, people realize that if I can do a little more, that instead of giving a single shot or a continuous catheter-based technique, can I do something which can take the pain management for long? And this is what they came out with was the intercostal nerve cryoneurolysis, where a direct application of the cryoprobe into the intercostal nerve, again the same space as well as 2 spaces above and below, a kind of kind of cuts off that particular intercostal nerve. However, it spares the endoneurium and the perineural connective tissue, which is why the intercostal nerve regenerates, and then you get the sensory inputs over that area. Is it good? Yes, it has been shown to be very good, and especially in the initial period, it has been very good, decreases parenteral opioid requirement and other NSAID requirements. However, the long-term outcomes have been not that very good, and there is also this high incidence of development of neuropathic pain, dysesthesia, and intercostal muscle paralysis, which is why I possibly think that it has not caught on in a big way. Otherwise, it sounds very, very attractive. The other thing that has really come back into clinical practice is the paravertebral nerve block. And this has come back ever since that people have started doing certain thoracoscopic procedures, especially in the West, as a daycare procedure. So you do not want a kind of an epidural block on a patient who goes home. And there have been publications which showed that the efficacy of pain management has been nearly as good as an epidural without the detrimental effects of a bilateral block that develops with an epidural. You can give it as a single shot. You can also put it as a continuous catheter-based technique, but this publication by Karmakar et al. Showed that the reason why there is a high failure rate of a paravertebral nerve block is because of the interference by the endothoracic fascia, and it has been suggested that by ultrasound guidance, the success rate of the paravertebral block can be increased. These are certain publications which have shown that the paravertebral nerve block is as good as thoracic epidural, and in fact this meta-analysis published in the BJA in 2006 actually showed that in most of thoracotomy procedures as well as VATS, the paravertebral block is possibly as efficacious as a thoracic epidural. So it makes sense to use a unilateral block than a bilateral block. Now, this is another thing which I think came into clinical practice because of the thoracotomy and the issues with pain is the issue of preemptive analgesia. And the concept is that you need to have a total afferent blockade before the noxious stimuli comes in, and if you can do that, you can have a goal of reducing the development of post-thoracotomy pain. And you see, the basic research again is that if you can block everything before the noxious stimuli comes in, and if you can block it with just the afferent block that comes in along with the humoral blocks using opiates and NSAIDs, then theoretically you actually reduce the incidence of the central sensitization that can take place. However, I think this entire business of preemptive analgesia, especially with the thoracotomy, was brought on by the Khaled group from the Scandinavian countries. But over the years, many people have questioned preemptive analgesia, and especially in abdominal surgeries, in limb surgeries, that preemptive analgesia actually does not translate to better pain relief, not only in the immediate postoperative period, but also in the long-term basis. But as far as thoracotomy is concerned, I think, though the jury is still out, but it possibly does a little better than abdominal surgeries, possibly does a little better than limb surgeries as far as preemptive analgesia is concerned. And the primary reason that people have argued for preemptive analgesia in thoracotomy is that the noxious stimuli is very, very intense. So the chances of central sensitization is much more. So if you can block it earlier, you decrease this. And the area of this noxious stimuli is actually less than, say, possibly a kind of an abdominal surgery where the area of stimulus is a lot more. So there are evidence which shows that it can at least, may not give as good as benefit in the immediate period, but as a concept, it holds promise that it might prevent in the development of chronic post-thoracotomy pain. So it can be used for thoracotomy. The reasons, again, Kissin has said that you need to kind of block not only the afferent inputs, but you also need to block the humoral inputs as well, which is why you need to give in not only the epidurals or whatever the paravertebral block and the local anesthetic that goes in before the impulse starts, but also your huge amount of opiates and possibly a huge amount of the NSAIDs before the stimuli comes in. Finally, we will wind up with the stigma of thoracotomy, which is the chronic post-thoracotomy pain, which is kind of termed as the PTPS, and the IASP kind of defines it that it has to persist for at least 2 months after the procedure, and we all know that this is virtually like a neuropathic pain because it comes with dysesthesia, burning and stabbing. If you look at numbers, it comes after surgery, and as we discussed that it can happen with just the traditional thoracotomy as well as with VATS. Incidence is nearly 80% at 3 months, and it does not really go down so much, 75% at 6 months, 61% at 1 year. It's a major issue. And severe is 3 to 5%, but 50% of them have pain which incapacitates them and prevents them from having their day-to-day activity. Mechanism, primary thing is the intercostal nerve damage. Other things that we need to rule out is tumor recurrence, and then it comes type of the incision and the costovertebral costochondral junction destruction, ipsilateral shoulder injury, preoperative anxiety. How do we treat it? First, rule out tumor recurrence, and then all the plethora of drugs that we already discussed can be used. Certain interventions have been tried, including neuromodulation like field stimulation, spinal cord stimulation, and dorsal ganglion neuromodulation. So the key points of post-thoracotomy pain management is that yes, thoracotomy is possibly one of the most painful surgical procedures. To treat it, we need dynamic analgesia. That is, not only is the patient pain-free, is able to move, but also is effectively can cough, and there is no respiratory splinting. Epidurals are possibly the best, but multimodal management is needed. Preemptive analgesia. Okay. Preemptive analgesia may or may not be helpful, and be aware of this post-thoracotomy pain syndrome.